It's a pleasure to be with you today. My name is Rashad Massoud, and I am the Senior Vice President and Chief Program Officer for Americares Foundation. I'm based in Washington, the Washington, D.C. area, specifically in Bethesda, Maryland. Myself, I'm a physician by background. I have been in healthcare improvement for over 25 years. I've played multiple roles, from the head of improvement in my home country, Palestine, to the director of USAID's healthcare improvement and applying science to strengthen and improve systems projects at a company called University Research, and today in my current capacity at Americares. I started as an improver and gradually became the talent manager, leading a lot of improvers in doing the good work that they do. And at this stage, I'm in an executive capacity supporting multiple teams working on improvement in different places. In my work, I have worked with 104 countries, traveled to 91 of them. So it's been a long journey in improvement, and I'm very excited to be with you today. I will ask my colleagues, Harsh and Celestina, to also introduce themselves, and we can talk more about the presentation in a minute. Thank you. Please, Dr. Harsh.
Thank you, Dr. Rashad. Hello, everyone, and welcome. I'm Dr. Harshwardhan Dere. I'm Director Programs for Americares India Foundation. Right now, I'm leading community health as well as some government partnership programs like Health and Wellness Center. Before this, I was also working with Engender Health, and basically whatever we do is for the quality improvement, for the health system strengthening. And I have been in this field from the last 18 years. Right now, the programs are going on in around 29 states of India, which we are overseeing. So thank you, and over to Celestina.
Hi, everyone. My name is Celestina Ajakum. I am the Chief of Staff Programs for Americares. I work directly with Rashad in all of programs. In his words, I do what he does. Whatever he's doing, involved in, I am. But that is just a funny note that we like to share between ourselves. I work with him in also programs on relationship management, change management, and as the name suggests, Chief of Staff, I do wear a couple of different hats. So I'm here to support the team and to be of service to everyone else. But please feel free to reach out if you have any questions. And we are very happy to present on this topic today. And also, if we do see you in Brisbane in October, it will be wonderful to have you in the workshop as well. Thank you.
Thank you, Celestina. Thank you, Harsh. And if I may now proceed to the presentation itself, let me share my screen so you will see images have changed a little bit. Let me also bring this down so that I can see. Wonderful. Are you able to see my screen? Can somebody just give me a thumbs up that the screen is?
Perfect.
Thank you. Wonderful. Well, today this is going to be a tag team presentation, and then we'll open it up for questions and comments. So we'll spend about a half of our time in presentation and about a half of our time in discussion. A couple of years ago, I joined Americares, and one of the things that I was asked to do is to deepen the programmatic impact at Americares. And so as I was trying to think about how one does that, I thought, well, the best thing that a program group can do is to better the health of the people that we're serving. You know, we're in the middle of the pandemic. We had a lot of issues coming up here in the country. And one of the things that became very high on our agenda was the whole issue of equity. And so I said, why don't we address health equity, which is the direction that Americares has taken, improving the outcomes of the care that we provide to our patients or that our partners provide to their patients as we're supporting them, and addressing issues of health equity. What we're about to present today is one of the first results that we have achieved at Americares in specifically improving outcomes of care and addressing health equity as part of that. Now, I'll say a couple of words about how we went about it. It's all deeply embedded in the science of improvement. The scientific basis for improvement, which is if we continue to do what we're doing, we will continue to achieve the results we're getting. If we want a different result, we have to do something different, something that enables us to get those better results. That means at the heart of any improvement is change. However, we also know that not every change necessarily yields an improvement. Some changes may not yield improvement. Other changes will make things much worse. And so the only way we will know is to continually measure. And so our data systems in improvement are all about frequently collected data over time. And you will see that in the work here, that we tested multiple changes, many changes, and we continued to measure over time in order to see that. I'll get into details a little bit later, but that's the hallmark of the work that we did. And in addition to address health equity, what we also did was to say, can we look at the outcomes of interest? And we had one particular outcome that Dr. Harsh will talk about in a minute. And can we stratify our data on that outcome by different potential causes of inequity? And if we uncover any, then address them. And again, we will be talking about. So two key things: change using PDSA cycles, which many of you may be familiar with or actually using, but we will talk about them, and also stratification of data to uncover potential causes of inequity. So I'm going to stop here. And also, the last thing I want to add is that as you come to the workshop, we're not just going to do a presentation at the workshop. What we are going to do at the workshop is to enable you to, I'm sorry, I keep switching because I see people coming in and I'm admitting them. What we're going to do is to give you the know-how, the methodology by which you can do the same thing in your own setting. So that's a key part of coming to this workshop. It's a how-to workshop, not just a presentation. I'll stop here and turn over to Dr. Harsh, please.
Thank you, Dr. Rashad, for setting the context. Now, where was this study or where was this intervention done? So we have mobile health centers that run across 13 wards of Mumbai, 8 of these mobile health centers, and which principally serve the urban slum population of Mumbai. As you know that Mumbai is already a very congested city and the slums are much more congested, and they lack the access to better healthcare services. They lack the quality healthcare services. So as you can see from the picture, this is the first picture and it was taken during the pandemic where all our people are wearing hazmat suits. So our mobile health center is parked at a space identified by the community where they park their vehicle. And then we have 4 of our staff, which I will elaborate later, who provide these services. Along with the consultation, prescription, and clinical services that we provide, we have also added a component of health education to the whole gamut of services that we are providing over here. So this is the location where we have done this intervention. Next slide, please. Now, something more about how this mobile health centers program started. We started at least a decade back with just a single mobile health center. It was in 2011 when we started this mobile health center, and we just covered 1 ward, 1 slum population. After that, slowly we progressed, and in 2015 we reached around 4 mobile health centers, and now we have 8 in 2020, since 2020. We serve across Mumbai 13 wards, and we have 130 locations that we serve through these 8 mobile health centers. We serve each of these locations every 15 days. Every fortnight, our mobile health center reaches that location and serves the population. So we are staffed with around 4 persons, as I mentioned before. That is a doctor and health educator who provides that health education, health awareness to the patients while they are waiting. Then there is a data assistant who takes all the vitals and also mentions whatever symptoms at first go that the patient is telling. And then there is a dispensing assistant who also acts as a driver, and he also dispenses the medications. All these services are free of cost. Even the medicines that are given to the patients are free of costs. And we have, for patient data, we use, because data is what we are going to speak about. So we use an electronic medical record system where we have a tab for each of these mobile health centers, 3 tabs. One is with the data assistant, one is with the doctor, one is with the prescription dispensing assistants. And we also have a referral services to government hospitals and trust-based hospitals, especially the subsidized care services, because our clients are very, very poor and vulnerable. Next slide, please. So this is how the picture looks when we are providing the services. From the left-hand corner, if you see, this is, I think this is from the Aries van, and I would like to mention that each of our van is mentioned, is named after the zodiac sign, so that it can have a global acceptance of sort. So this is where, from the left-hand corner above picture, this is where the first point of contact is between the patient and between our patient registration clerk or the data assistant, who takes all their vitals, and then the patient goes to the doctor for consultation. So we have a nice examination room, and it's very small that fits in that mobile van with the patient. And then the patient goes and takes the medicines, which are given free of cost. And then whichever patients who are in the waiting area are given health education. Now, as we started on this journey, I would say for health equity and also for improvement, we identified hypertension as an outcome indicator for us. In the sense that when we looked at the initial data, and we were looking at it from years, and when we really took a deep dive into that data, we found that our hypertensive patients were having blood pressure control just around 50–55%. So half of them were uncontrolled, and they were not improving. We were not seeing that type of improvement that we would like to see after such a long years of being with the community and serving that community. That is from where we started this. And as Dr. Rashad came in with his guidance and with the mentorship that we received, we moved to having that stratification of the data, having that analysis of, is it just the services that we provide, or also there are other factors which are affecting our health outcomes. And we did that analysis, and we found that, and that will be much better explained by Dr. Rashad in the next coming slide. So we found that there was a gender inequity gap between males and females, where females were doing much better than males, and it was around 20% gap that we found. And we understood that there are certain kind of things that we will have to make those changes happen, so that the males also do a better. We also understood that we have to do something much more for the females as well, so that there should be a rise in their control levels also. And at the initial start, we decided that we would aim for a 75% control across all the mobile health centers. Now I will hand it over to Dr. Rashad for going into the details of health equity. Over to you, Dr. Rashad.
Thank you very much, Dr. Harsh. As Dr. Harsh was speaking, I noticed colleagues who have joined. Sonali, welcome. It's fantastic to see you here. Let me now pick up from where Dr. Harsh ended and sort of go into a little bit of detail as to how we went about doing this and what were the results achieved. And I'll flip back to Dr. Harsh at the end for other comments. So the first thing that we did was we considered the approach. We had decided on hypertension as the area. We decided on blood pressure control as our outcome measure of interest. And the first thing that we did was we started to measure several data points before any intervention was started to give us some sort of idea of the baseline, which is the normal thing that one does. And then we started to look at how does this data change based on some stratifications of potential causes of gender inequity, of inequity. So we looked at gender as one, we looked at age as another, religion, and geographic placement of the patients, different areas that are geographically distant from each other. And we stratified the data by those four potential causes of inequity. The one that we found to have an inequity in was gender. We found that the males are not doing as well as the females in terms of their blood pressure control. So that gives us a place to start to think about how do we do this. So the conversations were with, as Dr. Harsh said, both males and females, but we were specifically looking at how can we make care better for everybody, but then why are the males not doing as well as the females? And all sorts of reasons came up, things like, most of them have to go to work in the morning. So during the time of the clinic, they're not available to come to the mobile health center when it arrives. So different changes were tested at different mobile health centers, and Dr. Harsh can tell us more details about those later. But things like, for example, having a priority list for those who are going to work to come in earlier and be seen at that time, or to arrange different times that work for them. So different changes were made in order to achieve this or bridge that inequity gap that existed between males and females, whilst at the same time thinking about how can we improve care overall for all the patients that we had. Now, again, different changes were tested for how we can do that. The main methodology that was used for doing this was, of course, talking to the patients, after uncovering the inequity, talking to the patients to both figure out with them what are the reasons and come up with solutions, changes that we could test and implement to see whether we can improve care overall and bridge the inequity gaps. And the way that we did those was using the Shewhart cycle for learning and improvement, the plan, do, study, act cycles. That is, we see that there is we have a change that we want to test. We figure out how we're testing it, when, where do we start. We look at the results of the tests as soon as possible. Dr. Harsh was basically leading this whole effort on the ground, and he was reviewing data every couple of weeks to make sure that he's learning about which changes are working where, and of course, also sharing amongst them. So those are the two main things that we were engaged with. What I'd like to do now is to sort of walk you through the results, but also ask Dr. Harsh to provide more details on that. The result I'm going to share is for all 8 mobile health centers combined when we come to the actual workshop where we have more time, we will actually share some specific ones, and you can see some very beautiful nuances there. So this is what you're seeing here is a time series chart, a time series chart being an indicator plotted over time. And the indicator is percent patients presenting to the mobile health center whose blood pressure is controlled. And that is the black line in the middle. So that black line in the middle is the total percent of all patients whose blood pressure is controlled. And as you can see, we were hovering around the 60% mark before the intervention was started. And so the intervention started sometime last July. And we started to see some improvements, but then the second COVID wave hit, which was followed by the Diwali festivals, and a lot of people left homes, they go to visit relatives, etc. And not much progress happened until the COVID second wave subsided. People were able to access services and people came home from Diwali festivals, etc. And what you see there is an improvement, visible improvement, and that actually is also statistically significant. But then after that, the third COVID wave hit and things started to deteriorate a little bit. And after that, everything picked up. And towards the end, our blood pressure control went from a pre-intervention percentage of 61 to a post-intervention of 91.9%. That's a remarkable improvement in blood pressure control for all patients combined. The interesting part here are the two lines, the red and the blue line. The red and the blue line are red for females and blue is for males. So that's basically of the, somebody's drawing on the chart. Okay, so the red line is females, and as you can see, right at the beginning, before the intervention, we had a 10.1% gap between females and males. And as we started to work on both improving care overall and addressing health equity gaps, we can see that the blue and the red lines were converging, becoming closer and closer. And at the end, you can see that that gap dropped from 10.1 to 3.1%. You'll see a little blip in the blue line towards the end last March, and that basically represents a very small number of patients. So it's an anomaly. It doesn't represent the total population at that time. Let me stop here for a minute and ask Dr. Harsh to add anything that he wants to this result, and also maybe describe some of the different changes in different places. We don't have they're not annotated here because this is sum total for all mobile health centers, all 8 of them. Please, Dr. Harsh.
Thank you, Dr. Rashad. So, yes. So, as we began our journey, we started with changes that were easily discerned, I would say. We started with strengthening the follow-up through telephones or through forming WhatsApp groups, through the mobilization from the community health volunteers. We found that some of the changes did not work. We also went into to ensure the adherence of medications, like giving them 15 days medications and then calling them back for the next 15 days medications. We also have changes that are related to the referral, because we are there just for 1 day in 15 days, and the rest of the day, if something happens to the client, then they have to go to the nearest healthcare provider. So we also looked into that, how we can have more strengthening than on that. What we found was, just to give you an example, was about the referral network assistance. What we found that because we are not giving them any patients except for the medication and telling them that they have hypertension, we don't give any paper document for them so that they can take it. If they visit another doctor, they can take it with them. And this started when we introduced our electronic medical record system. So what was happening for few of the male patients was that they were identified as hypertensive, and they were started on a treatment. But between those days, their health, somehow they had another health problem, and they visited the nearest healthcare provider. And that healthcare provider, when they measured their blood pressure, it came to normal, and they stopped all the medications. And when after 15 or 20 days, the patient returned to us, they were again, the blood pressure was not in control. So we thought that giving a health card to the patient will be beneficial. And this came as a finding in between from all the mobile health vans, and we introduced that health card for the patients. That was one thing that we had stopped doing, and then we have again now started doing. One thing that came to our attention was that just to add, is that all these mobile health centers have different geographic locations. So there is quite a versatility in the base, in the client base that they are serving. Some populations are from, say, Tamil speaking state or South Indian state. Some populations are predominantly North Indian states. Some populations are basically local, but from other districts of Maharashtra. At some locations, there are more Muslim population. At some, most of the locations, there are 50-50, and many of the locations there are more Hindu populations. So all these things have an effect on how the outcome varies. We have one Capricorn van where both these things, both our health gender inequity gap as well as the blood pressure improvement improved. While at say for Aries van, the gender inequity gap decreased, but there was not a significant improvement in the blood pressure level. Another of our van had an improvement in blood pressure level, but not in gender inequity. Where gender inequity increased, we have that kind of findings also. So the results vary. And lastly, I would mention that this is still ongoing, and it is not a stop process. This will be continuing, improvement work continuing, and we are still finding results where we will have to take a deep dive to find out what exactly the reason is. Like Dr. Rashad also mentioned the spike. So why is there a spike? So we try to find out through the data and through talking with the mobile health center team. What is working for us? What is not working for us? Why is there this data variations, so forth and so on? Over to you, Dr. Rashad.
Wonderful. Well, with this, I think our sort of presentation has come to an end, and we're at about half of the time. What we'd like to do now is to open it up for questions, comments, for discussion. As I said, what you can expect to see is more details on the presentation when you come to the workshop, as well as you will see the how to and get to sort of play with it a little bit, design your own project type of activity. So with that, let me turn over to you. I'm going to take the slide off and ask you to, so that we can all see ourselves, and then see who would like to start us off. So or Celestina, are you able to see any hands up or?
I think Katrina is handling that. I see her in the chat.
Katrina, please,
Yeah.
Katrina.
Oh, we have an echo. Has anybody got any questions? Celestina, I don't know if you want to share the poll. Would you like that?
Yes, please go ahead.
Great. I'm just going to launch a poll here for everybody. Yeah, about the measurements that you monitored. Apart from blood pressure, are there any other metrics that were affected?
Should I take it, Dr. Rashad?
Please, yes.
Yes. See, we do monitor all the vitals of the patient along with the BMI also. And of course, there, along with the health behavior, health seeking behavior awareness that we are giving for the people. So of course, there are changes which the doctors have mentioned to us, that there is positive changes in the health seeking behavior, also on the healthy behavior, which has affected the vitals that we are taking. But we have not monitored them continuously. Means that is done by the doctors for individual patients. We are looking at hypertension as a whole for our health outcome for this mobile health center program. I hope I have answered your question. Dr. Rashad, you would like to add more to this?
No, I think you've answered it very well.
Right. So there is one more question. How did you manage to provide free medication? I will take that first, that we have Royal India Supporting Trust. So this is a trust which supports our program of mobile health centers, and they have been kind enough to support us continuously, and very happy to have those that kind of support. Yes, Sonali, you have raised your hand and I will be coming to you. So another is that how did you ensure follow-up? So we tried those changes, right? Like we just pandemic was there and people were still apprehensive to come to the mobile health centers. There was a fear for COVID-19 as well as what kind of services will be continued at the mobile health center. The first thing we started was, if I have to just line up few of the changes that I can say, was telephonic follow-up. We formed WhatsApp group. We even did mobilization through our community health volunteers. So our community health volunteer is a person who is from that community itself, identified, and who works with us for two hours during that period, and it is completely voluntary, means no payment is given to the person. So these are some of the very good community members who want to align themselves to our work. So that mobilization through them, and we also tried home visits by our own health educators. There were two things that worked. One was mobilization through this community health volunteers, that worked. But most efficient was home visits by our health educators. That were most efficient that we found. But when we did speak with the mobile health center team, what was much more feasible for them. So doing home visits for around 50% of the clients, patients, is not a feasible way to go. So we had to discontinue that change. And we did continue with the CH community health volunteers mobilization.
I believe Sonali has a question.
Sonali has.
Hello, Dr. Harsh. Hello, Rashad.
Wonderful
Nice.
to see you, Sonali.
This is hearty congratulations, Dr. Harsh. This is quite remarkable, because even within a quad, it is often very challenging to do quality improvement work. So doing it in a community setting where you have so much variability, like you described, from one van, from one community to another, and being able to, experiment and improve things is quite, quite a significant achievement. I have one question. We generally struggle with this. So, when we work on things like, weighing babies or checking blood pressure, often we realize that there are differences in how people actually even take the blood pressure. So often even the blood pressure readings are not accurate. And as we keep doing the project, how people actually measure the thing also improves. Did you notice of how they measure blood pressure?
First of all, thank you for the kind words, and that is an excellent question. So at our mobile health centers, we have a standard operating procedure, and we do follow that. You must be knowing about the India Hypertensive Control Initiative, and they have nice pictures that have been come up, nice collaterals on how to measure blood pressure, and that is what we have also passed on to our mobile health centers. Each of our mobile health centers has basically MBBS doctors who are responsible that these standard operating procedures are monitored by them and also followed by them both. And during our visits, supportive supervisory visits, we do ensure that those are being followed up. I hope that I have answered your question. But one thing is interesting, means one thing I want to mention, because it is such an interesting thing, that for our, because the first point of contact, the patient registration person, they also take the blood pressure. And we had to somehow, during our monitoring visits, we had to tell our doctors to follow the protocols and not that the registration person. So yeah, but it is a continuous, as I said, that it has to be continuous. You can't stop at one place and say, okay, now everything is perfect. We have to be continuous, because there will be always be gaps.
If I can just add, I think Sonali makes a really important point, and we've seen this in other work. When Sonali and I were working together, we saw this in multiple places, that actually once you start an improvement activity, you not only improve, you're not only making changes to the care that you're providing and the way it's organized, but then the people start to become much more diligent about how they do the everyday procedures. And so you do get that improvement in the quality of the measurements, like blood pressure measurements and others. That is a widespread phenomenon, and I would say if one is not sort of in this particular case it was fine, but in other places one might want to double check that as well and make sure that they are verifying that this is not just an improvement in the measurement itself, but an improvement in the care. And of course, the measurement is not going to yield a 60 to 90% improvement. That's not likely to happen, but certainly is something to pay attention to. Thanks, Sonali, for bringing this up.
Yes, now there are two hands raised and there is a one question pending from ISQua. So let me take ISQua first and I will answer it in short. At the initial, when we wanted to start that, we had some information. We wanted some information about the socio-demography of the patients, and we did a kind of small survey to understand who gave them information about the mobile health centers. It was like we found out it was only through, so it is more of a word of mouth. And then on the second thing that came up was from the government side also, people told that there is a mobile health center nearer your home, so that you can visit that if you are finding it hard to come to the public health facility.
Great. I think Hasib Awan was next. Hasib, would you like to ask your question?
Hello, can you hear me?
Yes.
Hello, thank you very much for giving such a nice presentation. Well, my question, I think, is beyond the scope of this, beyond the topic. But I'm from Pakistan, and in the government sector right now, quality improvement initiatives have started. As the Dr. Saab is from India, and we both of our countries face the same problem, is a lot of patients. We have a load of patients in our hospitals. So improving quality becomes a very big challenge to us, especially in the public sector. So which area in your experience should be the first area that quality improvement champions or quality department should look into while trying to improve quality in a public sector hospital where there's a OPD of 8 to 10,000 per day?
Sure. Would you like me, let me start. So I had a very similar experience back in my home country when I first started improvement. I was actually still practicing medicine at the time, and I was working for the United Nations Relief and Works Agency, where on average, I had about 100 patients come in every day. It was mind-boggling to be able to deal with them, especially for a young physician who's trained to do everything and has not yet sorted out how to sort of maneuver very quickly. So I used to literally, I tried multiple things, like, for example, 3 examination rooms, have everything ready, go in and all of this. But then within a few months of doing that, I realized that actually I'm seeing a lot of patients that I probably don't need to see. So luckily by then I had been introduced to improvement. And what I did was I started to make a note. I had my own record of which patients, and I would note, you know, the name, and then I would go back to the charts afterwards and I would look at them, and I realized that there are categories of patients that could be served differently. Some patients absolutely need, you know, the full examinations. Other patients may be coming in for a repeat prescription or just a very simple or a minor thing that can be dealt with much quicker. And so the first thing I did was to start to look at different patient categories and who needed what. And then I started to talk to a patient, say, if this is all you need, then just make sure that you say that so that we can, and for them, it's actually much better because they can come in and get what they need much quicker. But of course, you know, that reduced the workload significantly. It just, you know, categorizing what are the needs of different patients upfront and having that conversation with the patient and the staff, and then reorganizing work based on that. That worked very well. Now, in a hospital setting, it might be a little bit different, but again, even I've also worked more in hospitals actually than primary care clinics. Again, you know, once you know the patient, then, you know, you don't go through everything all over. You start to be very sort of like targeted. I've seen this patient before, and you know, you ask him what's going on. I think one can make those classifications as opposed to start with everything as if it's the same. So different stratifications, different categories of patients, and dealing with those as the patient needs are. That's been my experience, and I've run a couple of improvement projects of that sort in the past. I don't know if Dr. Harsh or maybe any of the other participants would like to, please, Dr. Harsh, would you like to add to that?
Yes, simply put, you have exactly come to the point, Dr. Rashad. In India as well as in Pakistan, more of our numbers or more of the data that we have good data right now. Means in the past there was, I would say there were many gaps on the data sets, but right now we have good data sets. And looking into that data and trying to discern what exactly we need to do, where we need to focus on, and how we can go about improving that would be the first place to start.
Right.
I concur with you.
Let me open it up to others, because some others may have experiences in this area that they would like to share. Anybody would like to talk about this point before we go on to the next question? Please unmute yourself and speak if it's about this point.
Yes, so I didn't catch the name of the person who asked the question, but yes, this is a common problem we face in both countries and many other countries. And one of the things that I've learned from Rashad basically is to start simple. if we think of the whole hospital and the thousands of OPD patients, it becomes like an overwhelming issue. So maybe even begin smaller, maybe, in, one ward or one unit where you have more engaged staff who are willing to work on an issue. So picking up something that's very simple and that affects a large number of patients. And not picking up a problem initially that affects only a small number of patients. And, there are ways to have this conversation with staff and to decide on what's something that is relatively simple to fix early on, and then slowly move on to more complex things.
Thank you, Sonali. That was great. Any other comments on this? If not, can I turn over to Juan, please?
Hi, Rashad.
Hi.
Hi. Thanks you for your fantastic presentation. And my interest is note about what challenges are you tackle during the interventions in this project, specifically about, for example, the compliance of the patient compliance about taking his medications and other issues such as the patient engagement, for example, in order to get the aims that you are set up at the beginning.
Great. Let me ask Dr. Harsh to comment on this one, on this question regarding this particular project that we just presented. And after that, I'll talk a little bit about other experiences where we really had to address issues of patient engagement and compliance with treatment in other areas. Please, Dr. Harsh, would you like to take this?
Yes, and of course, there is always a challenge of adherence to medication. I would say that giving free medication helps, because those people, when they get free medications and they get the kind of health education or health awareness talk from the health educator, as well as a continuous reminder from the doctors in charge on how to take the medication, why is it important to take the medication, and these are lifelong medications. So this has to be repetitive. This can't be done at only one point. Few of the patients, of course, faced, like I remember a challenge, adherence to medication. I would say the challenge was that they should have the medication, and some of our male patients timings didn't match with the timings of our mobile health centers. And our doctor can't decide so as to continue that very medication, or there is a change required. And we tried two of the things I remember is that one was giving token to the male patient so that they can come up early and just be taken up on the priority so that they can go to another place of work. And in Mumbai, usually the place of work is at least takes around 1 hour to 2 hours to reach. So that didn't work for us. Another thing we tried, as I mentioned, was identifying a very nearest local healthcare provider, so that that healthcare provider can measure the blood pressure, because they are there, they come every day, and then inform our MSc people, because we have a referral network partnerships with all these people. So that surrounding is there, and these people told that, okay, the blood pressure is normal, the drug is working, or the blood pressure doesn't seems to be controlled, and then the doctor can take a decision, and they used to give that medication to the family members so that that medication can be continued. If they found that the blood pressure is uncontrolled, then they would insist that the male patient should visit the mobile health center. So this is just an examples that we found in the field level on how we did it. I'm sorry, you had a second part to that question.
Yeah. Do you set any metrics about the adherence to medication or engagement, patient engagement in this project? Like does percent of the patient that were taking 100% of their medication? And
no. So it was it directly reflects in the hypertension control itself. We didn't set that type of any metrics, but it is a good idea.
thanks.
We can think
Thanks.
about it.
So the big place where this came up in our previous work, the work, for example, with Sonali, was in the HIV/AIDS arena. And early on when ARVs first became available, people were really keen, but then all it took were a couple of years, and we started to see that retention of patients on treatment, the compliance part that you're describing, actually was pretty low. It ranged anywhere from around a half of the patients were retained regularly on treatment, and for all sorts of reasons. Some did not feel that they needed the treatment. Some could not tolerate the treatment. Also, and then of course all the conversations that were happening in communities and all the rooms. So we had a major issue there. And in tracking basically our success in AIDS, one of the things that we did was we thought, what is the measurement system that we need to have? And it's actually published in the AIDS journal. And we thought the way to do it is to look at every patient who needs treatment gets treatment. Every patient who is put on treatment remains on treatment. And every patient who remains on treatment does well on treatment. So we had 3 lines that basically on the same time series chart, we were drawing 3 lines: needs treatment on treatment, put on treatment, retained on treatment, and then retained on treatment, doing well on treatment. And we were measuring the gaps between those lines, just like we're doing here, and seeing them converge. And that was the secret. And of course, we would literally pick out patient files. We would look at the patients who are not, and we would be talking to the patients, trying to understand why they're not compliant with the treatment, what's getting in the way. And we found all sorts of reasons that we had to address. But it is an important issue that you bring up. It comes out, I think, with hypertension. I haven't seen it as much with hypertension, but certainly with HIV/AIDS, that was definitely one of the big problems we had to solve. Thank you for that question. It's a good one.
Thanks.
Any other questions? We have a couple of minutes, and what I would love, I'm looking at the poll, and there's a question that's intriguing me. We have a couple of people who have said that this approach would not work in your organization. If you're comfortable just sharing with us why not, and what do you think would work, I would love to hear from you. Anybody who answered that the first question, that it would not work in their organization, please tell us about that. Why would it not work? Okay. So if you're not comfortable, that's also fine. Not a problem. Any other questions or comments?
Rashad, I think, did you see, I think someone answered your question.
Oh, on the chat?
In the chat.
A lack of people, to do follow-up. Thank you. That's a great, okay, so that comes with small entities. And when I was describing my work early on, literally the health center had maybe a handful of staff. And so I was not only the improver and the leader, but I was also the data collector. And I was the one who was asking the patient. So, you play those roles all together. And I think that's That's a really good one. Thank you for bringing that up. But there are ways around it. Providing free medication, yeah, that's an issue. I see John's hand up. Please, thanks, Celestina, for pointing out. John, please, would you like to say something? And again, I want to acknowledge John and I have worked together for many years. It's wonderful to have you here, John.
Thank you, Rashad, and thank you for the webinar. Again, another classical example of how improvement science can be used to improve the quality of care that people receive. I was really happy to see how the gender gap was able to be narrowed over time. And also speaking about the HIV work many years ago, when we did that work at that time, I remember we called it the ART framework, addressing the gaps between those three variables, which later got to be called the 90-90, now 95-95. Each time I hear people talk about the 95-95-95, I always remember that some years back we're doing this as ART framework. So thank you for always being available to share your experience and expertise.
Thank you, John. And I remember wonderful days working together in the trenches in Uganda. It's wonderful. Thank you. Yes, of course. And that was sort of like the precursor for 1990 and 95, which UNAIDS said. Wonderful. I think we are 2 minutes away from the end. Maybe this is the point at which I can, first of all, thank you all very much. This has been a wonderful engagement with you. I hope that we will see you in Brisbane and we'll get to share more together and listen to you more. But this is maybe the moment I hand over Harsh and Celestina, if you would like to say a word, and then pass it on to Katrina after that.
Yeah, thank you to all the participants. And I would say that maybe the local context will change and it will keep on changing as we work in different demographics, different geographies. But this approach will work. So we are hopeful to see you at bigger workshop. Thank you.
Absolutely. And I would just add, I took a couple of screenshots of the results of the poll, and most people are interested in the health equity approach and the rapid PDSA cycle. So we'll see how we can adjust that in the workshop in Brisbane, but well noted, and thank you so much.